Your doctor offers you a cortisone shot for your knee. You've been reading about PRP, which stands for platelet-rich plasma. And somewhere online you saw that cortisone destroys cartilage, so now you're stuck. I'm Dr. Rainier Guiang, a board-certified pain physician in Riverside, California. I give both of these injections. Let me tell you what the evidence actually says and what I'd tell my own family. Cortisone works, it quiets inflammation, and for a lot of people it drops the pain fast. That's real, and I won't pretend otherwise, but here's what doesn't get said out loud. In 2017, JAMA published a 2-year randomized trial, a steroid shot in the knee every 3 months versus saline. The steroid group lost more cartilage, and at 2 years, their pain was no better than saline. That's the chondrotoxicity concern in a nutshell. Steroids are hard on cartilage cells, and it doesn't stay in the knee. Even injected locally, cortisone acts like a systemic drug. It spikes blood sugar. In diabetics, glucose can run in the 300s for a day or two. Repeated dosing is linked to lower bone density and higher fracture risk. Add skin thinning, tendon weakening, and a hormonal dip. That's why when a patient asks what I'd personally choose, I say PRP. But I want you to understand what you're actually buying, because this is where the marketing goes off the rails. Platelet-rich plasma is your own blood. We draw it, spin it in a centrifuge, and inject it back into your joint. Let's start with what it does not do. It does not regrow cartilage. Rigorous EMAREEYE studies confirm this. If a clinic shows you a picture of a knee filling back in, walk out. So what are you getting? An arthritic joint is chemically inflamed. The lining is pumping out molecules like IL-1 beta and TNF-alpha. Those molecules chew up cartilage and sensitize nerve endings so it hurts more. Platelets are your repair signaling cells. When we concentrate them, they release growth factors that do 3 things. First, they turn down those destructive inflammatory signals, IL-1 beta and TNF-alpha drop. Second, they flip the immune cells in the joint from a damaging mode into a repair mode. And third, they stimulate the joint lining to produce more of its own lubricating fluid. So here is the honest bottom line. PRP is a symptom-modifying treatment, not a structural one. You are buying less pain and better function for about a year. It's the difference between managing life and a replacement. PRP suppresses nothing and adds nothing foreign. You get relief without the cartilage and bone cost of steroids. In meta-analyses, PRP ranks at the top for pain and function at 12 months. Corticosteroid ranks near the bottom. But the RESTORE trial found PRP no better than a saline injection at 12 months. I'm not going to hide that from you. How do I square that? First, PRP prep quality varies. Second, nobody is offering you a saline injection in a real clinic. If that uncertainty bothers you, good. That's what informed consent is. Now the question you came for, if I get a cortisone shot, does it ruin my PRP? The answer is not settled. In tendons, prior steroid injections did worse with PRP afterward. But in the knee, a small pilot study found that steroid before PRP actually did better than PRP alone. What I do, if you've had cortisone, I wait. I want that steroid washed out, so we're not spending your money fighting your last shot. Just use it well. Space those shots as far apart as you possibly can to limit the cumulative damage. If you want to know which is right for your joint, book a telemedicine consult. The link's in the description. Please like and subscribe so we can reach more people with this information. Thank you for watching. This video is for general education, not medical advice. Talk to your own physician before starting or stopping any treatment.